Hello, everybody. Thank you for listening to the Healthy Project podcast. I am your host, Corey Dion Lewis. I have a great guest with me today. She is the CEO and founder of MAPA Healthcare Consulting, Gaby Alcala, which is a risk adjustment programs and transitions to value-based care. Gaby, thank you so much for being on the podcast with me today. I really appreciate it.
Thank you so much for having me, Corey. I'm very excited about talking with you today and about being in this podcast. Thank you.
Yeah, I'm excited to have you on. Not only because of your knowledge and kind of where your heart's at with value-based care, but we hear a lot about value-based care, but we often don't hear about maybe the back end stuff of it. And I don't know if that's more where you're at. And I would love to know more about obviously your passion for people and kind of where you're at with it with the value-based care, but you work a lot with healthcare organizations on making sure these things maybe work out for people. So I'm looking forward to hearing your thoughts. But before we get there, just tell the people a little bit about yourself and what gets you up in the morning.
Coffee, like a friend told me.
Amen.
Well, I have to say I'm a morning person, so it's very easy to get me out of the bed. To me, it's working on projects that are putting the puzzle together and trying to figure out how to do something better. Healthcare has been my area. My father was a doctor. And I didn't want to be a doctor, but I wanted to be in healthcare. And here in the United States, I have found that there's so many things we can do to improve the system.
Right. And you're doing that. So kind of tell us about, what is risk adjustment and who does it impact the most? Can you tell us, well, first, what is risk adjustment? What does that look like in a value-based care company?
Sure. I'm going to speak in lay terms. I don't want to use technical words here. So pretty much risk adjustment, what it does is kind of a methodology used so that organizations that are in value-based care can be I wouldn't say rewarded, can be compensated for the services that are providing to their patients. So in value-based care, when organizations receive a certain amount per patient, a capitated amount per patient.
Right.
But if a patient is sick with cancer or any other disease or another chronic disease, they get additional money so that they're able to take care of that patient in a good way, like in the right way.
Right.
So risk adjustment, what it does is a methodology used so that we can tell the payers and CMS how much else you need for that patient that you're taking care of.
Okay.
So that's the simplest way of saying it. So you might get $400 extra for a patient that has multiple complications so that you can take care of that patient the right way. But it's very complex because there are many things that happens in the back end so that that gets to your payers and they're able to say, yes, you need more money for that to take care of that patient.
Right. It seems, the more and more I get into learning about value-based care, you said it, there's so many steps to like what determines if organization gets X more money for a patient, or like there's just so much to it. But so how should an organization manage their risk to be successful? I mean, if there's so much that's going on in the back end, what should an organization what they should be thinking about to be successful?
Yeah, what I've been seeing, Corey, is that many organizations or many people getting into this, because this is a new world in reality, sort of new. It's that they think this is about coding. And if you think about risk adjustment, about coding and documentation only, you're missing a big piece to it. So to me, it's a workflow that starts when when you engage the patient comes to an appointment, to the moment you get paid for that patient. So there are many pieces to it that needs to be integrated and looked at. So for example, revenue cycle is a key component here. If you don't pay attention to your revenue cycle, no matter how much you do in documentation or how much you improve your EHR, if it doesn't get to the payer, you're not going to get that money to you. That's not going to be reimbursed to the organization. There is data that you need to be looking at constantly. There are things you can do in the EHR to make the work of the physician easy. There is training on the provider side to make sure that they know how to document correctly, because clinician documentation is not the same as risk adjustment documentation, unfortunately. So you need to train the providers to say the right words that will be in the kind of the risk adjustment work. So it's a very complex system that you need to look from the beginning to the end.
Right. So it's more than just providing good care to a patient. It's not only providing great care to a patient, but making sure that when you're doing those notes or you're doing all the things in the back end, that it also shows that you're doing that care for the patient.
Exactly. It's like documenting correctly that care so that when you submit that information to your payers, they can see that and they can it's not give back your money, but it's like compensate for that care.
Right. So giving all these new, and I don't know if they're new steps because I'm not a provider, so I don't know how they document. I know a little bit, but it's a little different than how I do things. How do you feel? And I mean, how do you feel that this new way of, with value-based care and this new system, how is this, or can this improve that relationship with the patient? Like, I know doctors are really used to a fee for service, or how things are now. But what are some of the benefits of this, and how can this improve not only the care for the patient, but that relationship?
Well, I think the incentive of the model are aligned to provide better care to the patients, because they're not incentive to give more care that is not necessary to the patient. Because in the fee-for-service world, for everything you do, you're going to get paid. Every single thing that you add, you get paid. In this one, the incentives are about taking care of the patient at the primary care level so that they don't end up in the ER or in inpatient care unnecessarily.
Right.
So it's really like a lot of the providers go into these new organizations in the value-based world because they feel they're going to provide better care to their patients and really ensure that they don't, develop worse diseases, and they end up using multiple levels of the healthcare system unnecessarily.
Right. So I read you do a lot with telehealth design and implementation. Where do you see telehealth and with risk adjustment and value-based care? What does that relationship look like? Is that a good thing, or what is that to you right now?
So I think it's a little bit complex to answer that question, because what I think great about telehealth is if we're able to reach out to those patients that are harder to reach. That's one thing that is great. And if we can allow for that also to be risk adjusted, it will be great. Although I think right now the video parts is adjusted. After COVID, they start allowing for that. But also, there's so many unnecessary visits to providers. If we can use telehealth for those visits where you don't need to go in person, you can provide that and save time to the patient. But right now it's very complex for the equity point of view, because although it sounds great to use telehealth in healthcare, there are many things that are impacted equity. Like there are people that don't have good connection, that they don't know how to use all these platforms like Zoom or Doximity or all these. And also there are privacy issues. Like some of the people, they may live in a house with multiple people and they don't want to talk about their health related problems.
Right. So it's a great thing, but there's just some issues that may need to be ironed out a little bit more before we can have a solid solution.
But I have to say that I'm glad that now with COVID, some of the visits are risk adjusted, which it wasn't before.
Right. Why was that? Why wasn't it risk adjusted? Do you think? Like, what's the issue there?
I mean, I think the same way that telehealth wasn't a thing in healthcare before COVID.
Right.
It's all the payments and send. Yeah. So.
Right. So, with risk adjustment, it seems like, especially for you, Gaby, it's a lot of work. Yes, you're not providing the care, but you play a big role in how that works for everybody. Would you agree with that? Like it seems like it's a lot to take on.
It is. I think it's a lot, and it's way more than organizations think when they first start working on this area on risk adjustment. So I've seen it with several of my clients that when we start working and I tell them all the things that we need to look at, it's kind of an awakening. Many didn't realize that all these pieces were connected.
Right.
And I think it's extremely important to find ways to make this easy for providers so that they can do what they're good at, which is taking care of the patient. But if we do risk adjustment in a way that it's a burden to the providers, where they have to document and really remember all the risk adjustment rules and remember codes and ICDs, will drive them crazy, and then they don't have time to provide care for the patient, and then they're going to feel, well, the fee-for-service world wasn't as bad either,
Right. Let's
so we need to find exactly. I mean, they leave that world because they want to take care of the patient, but when they come to this world of value-based, if we don't make it easy for them, they're going to revert.
Right. With a lot of the organizations that you provide your service to, what has been the biggest or the most common challenge that you've seen that they've had to adjust to?
I will say there are many pieces, but I will say one of them is revenue cycle. It continues to be one that, oh no, the revenue cycle department is somewhere else. No, I know they do their job, or we don't really have a revenue cycle person like working full time. And to me, that's like, it's very key. It's like, because again, like I said before, if no matter how much you do in the front part, but if it doesn't go anywhere, it's like it doesn't go to your payers, that information, then you're in a way wasting your time. Well, you're not wasting your time because eventually you fix it.
Right.
And the other piece I will say, there needs to be a lot of help, like having coders and what is called CDI, clinical documentation improvement specialists, helping providers with a documentation piece and the codes to allow providers to do their job.
Right. Because I can see how this can kind of be frustrating for a provider, where on one hand, you understand the value that it brings, but also not only do they have to provide, take care of this patient, but they also have to do all this extra work that may seem tedious, or sometimes maybe it is necessary, but may feel unnecessary. And like they're spending more time with paperwork than they are with the patient. Now they're trying to figure out how to make it all work.
Well, trying to remember what is the right ICD here.
Yeah.
They're not coders. So that's a key part to take that away from them.
Right, right. But the bright side of value-based care is, I mean, it is about the patient as well, and providing care for that patient. And once we get all these things, do you feel like with your experience in risk adjustment and being in the value-based care industry or in working in these systems, is there a light at the end of the tunnel? Can we see it yet? Or is there a lot more work that could be done to make it better?
I think we are moving in the right direction. There is still a lot of work to be done. There are many organizations right now that are trying to facilitate this workflow. There are companies that help you with the chart reviews, and they help you with what is called natural language processing. There are many things that are happening to facilitate workflows. The piece that is still needs to work out a lot, it's integration with the EHR. Because if the provider is working on an EHR, but then you ask them to log in another system, to do something else, to review the notes, or X, whatever you're doing, then you lose the provider there. So everything that you do in this area to facilitate the provider workflow, it has to be integrated with your EHR. And that is challenging.
Right, right. So it sounds like a big challenge,
Yeah.
But that definitely doable. I kind of want to switch a little bit here from talking about not just the risk adjustment, but really the population that I feel could kind of benefit from this the most. And those are people that are, struggling with, social determinants of health disparities, people of color, people of poverty in these certain area codes. How does this affect them? Like, I feel like it's a benefit, but from your experience, how does this affect those people that are at most risk?
Well, because in theory, their care will be better managed by primary care providers. So it's going to be a more coordinated approach to treating those patients. And many of these patients that you're mentioning here have multiple conditions.
Mm-hmm.
And so ideally, by having a provider that helps them coordinate their care better, it will be more beneficial rather than, going to the ER one time and then to another doctor and then not going anywhere. So if you're able as a provider in these settings to manage their care better, they will be better off. And I said in theory, because that's the theory behind this, the practice is a little bit harder.
Mm-hmm.
Obviously, it's a challenging population, but it's really having that primary care provider who understands your health, your overall health, and can help you coordinate all those other, all your chronic conditions or other diseases you have.
Right. But doesn't it seem like, with value-based care, I feel like there should be, we always talk about a team-based approach in value-based care. So it's just not the primary care provider that has to work with them. I feel like if a lot of organizations really take that on, and I'm not everywhere, so maybe there is people are really taking on this team-based approach. It just doesn't feel like it because a lot of, you hear about physician burnout and things like that. But
yes,
do you feel like a team-based approach can help with physician burnout, will help with a lot of these documentation, the things that you are bringing up that maybe a lot of providers aren't even considering, like, oh yeah, I didn't even think about all of the coding that I would have to do. Well, who's going to do, like, maybe they haven't really had this conversation, you know what I mean, or thought about it.
No, totally. So I have to bring a story when I was working at Iora Health, and they use the health coach approach,
Mm-hmm.
which is the health coach works closely with the provider to get to know that patient, to provide support during the care. So it's that team-based approach. And there was this patient who was missing their dialysis sessions many times, until one of the health coaches realized that if we provided them with it wasn't those mini iPods that existed before.
Yeah.
We don't see them that much anymore, but the small iPods with a playlist that they like, maybe that patient will go more to dialysis, and that worked. So it's something that you don't need a medical degree to figure it out, but it was more about getting to know the patient, knowing what the taste of the patient, what was going on, and a simple thing helped that patient continue his hair care.
Right. And it takes so much. That's a great story, because it takes so much off of the provider. The provider didn't have to try to figure that out, because they probably have 40 other people that are maybe going through the same thing, and having that health coach that can take the time to understand that is so valuable.
Yes, and you don't need, again, to know about, you don't need to go to medical school to realize that you could help that way. So these health coaches are normally not training medical school.
Right.
They may go eventually, but not necessarily.
Oh, right. Yes, I'm a health coach in a clinical setting. This is what I
great.
I love. I'm there. You know what I mean? Like, so everything you're saying, I love it, because it is so true. You don't need to have a medical degree to help a patient. You know, you can help a patient in any way. That is awesome. Gaby, so my thank you so much for being on the podcast and really talking to us about something that I feel like is so important, but no one really understands it, and shining a light on that. If anybody listening to this wanted to learn more about you and your consulting firm and get to know you, where can they find you?
Well, right now I'm in LinkedIn, obviously, and it's MAPA Healthcare Consulting, and under my name, Gaby Alcala. And there is all my contact information is there, and I will be more happy to help them.
Awesome. That's awesome. Gaby, thank you so much for your time. I appreciate it.
No, Corey, thanks to you. You're doing great work here. Thank you so much.
Thank you. I appreciate it. And everyone, thank you for listening to the podcast. I'll holler at you next time.